Hello, everybody. Hi, hi, hi. We are going live for today's Reshape Your Menopause show. Let me just check that we are live in all the correct various places. And I want to pin this. If you're watching us in the peri and menopause, sorry, in the Moving and Reshaping Club for peri and post-menopause, that is where you want to be because that is where I will be looking for questions and comments from today's guest. So one sec, I am just going to pin this post. There we go. And I'm going to pin it so that everybody can find it easily. If you're watching us, LinkedIn, YouTube, any other Facebook platform, welcome, welcome, welcome. I am Tracy Sider, and this is the Reshape Your Menopause show. I am host of the Moving and Reshaping Club for peri and postmenopause and creator of the Reshape Method program, which is an alignment, a body alignment reshaping program for peri and postmenopausal women who want to get in shape, be ache-free, and age audaciously, because that's what it's all about. They don't call it the change for nothing, and we need to know how to take charge of our change. And I do it in a movement alignment based way. And today's guest, Tamara Chaddah, and I will bring her on, is going to be talking to us. Tamara is a naturopathic doctor as well as a certified menopause practitioner. She's based in Ontario. Welcome, Tamara. And Tamara is going to be speaking to us about a hot topic, HRT, hormone replacement therapy or hormone therapy. Like nobody even knows what to call it any longer. Maybe we there. But I'm so excited for Tamara to be on with us today because there is so much confusion around hormone therapy at peri and postmenopause. And Tamara is here to clear it up for us. So welcome, Tamara.
Thank you. Thank you so much for having me. I'm happy to be here.
Lovely. Tell us a little bit about you, how you like got into like the whole menopause field.
Yeah. Okay. So that's a great question. On a personal note, I've been in practice for over 14 years and I've really, been in women's health for that long. And I hit perimenopause at a very, very young age when I wasn't expecting it, and it really threw me for a loop. And I think during that time, I was really struck by how few providers there are that can support us, particularly if we don't fall within what the normal definition is. And so through that process, I really wanted to be a part of the conversation and also to support women. And so who are going through perimenopause and menopause. So I transitioned my practice to really focus on this so that I can help women who are transitioning through this.
Amazing, amazing. That, yeah, like the do's, the don'ts, the yes, the no's.
Yes. Yeah.
So let's start a bit maybe with some definitions. And if anybody's
Yeah.
watching, let us know in the chat. Are you
Yeah.
confused about HRT? And do you have any specific questions
Yeah.
that you would like to ask Tamara today?
Yeah.
Because this is really, really a golden opportunity to clear some things up. So maybe let me hand over to
Yeah.
you
Okay.
and let us know what is the deal with HRT.
Okay.
And
Let's go. Yeah. So
okay.
as you mentioned, so I'll just kind of start with like a brief sort of overview. So as you mentioned, I am a practicing naturopathic doctor, and I'm also a Menopause Society certified practitioner. And so for those who don't know, Menopause Society certified practitioner, or MSCP, was formerly known as NCMP, which is a title that's given from the North American Menopause Society, or NAMS. And I think, NAMS really, it's a great resource. I'll list the website for anyone who is curious and wants to check that out. But NAMS, they recognized some time ago that there was a huge need to set higher standards in menopause care for women. And so what they did is they developed a competency exam for licensed practitioners. And so if you hold this title, essentially you've demonstrated expertise in this field, you've passed an examination, and you're staying current with continuing education. And, you know, the preparation for this exam is quite rigorous. And so I mention this just because one of my missions is to help people find an easy way to recognize those people who are going to give them informed education around menopause. And so if you're looking for a NAM certified practitioner, they're going to be up to date with sort of what the guidelines are saying with respect to menopause care. And they're going to be a good resource for you essentially to chat about different options. And so the NAM's website, I'll talk about this as well later, but it's menopause.org, has a lot of valuable resources, lots of handouts, and you can even search for a practitioner in your area on that website. And so as I mentioned, Tracy, you know, I've been practicing for 14 years, predominantly in women's health, treating everything under the sun. I hit perimenopause at a very early age. It threw me for a loop. And I think it's really interesting, right? Like you can know things in theory and you can know what the textbook says, and then there's the experience of what that's like. And the two are not always the same. And so my heart really goes out to women who are suffering in this transition. And so, like I said, I've always been passionate about women's health. But this experience for me really shed light on how much misinformation there is out there, how women are very underserved in this area, and how we all really need individualized care, support, and education. So I transitioned my practice to this, and I really want to be a part of the conversation that supports women through this transition. So as you mentioned, if anyone has questions about my practice, or as we're going through, if you think of questions and you throw them in the chat, I'm happy to stop and answer what I can. And then if people are catching the replay and you want to reach out, my Instagram is Dr. Chaddah ND. So you can check me out there if you need more support. So I think like before we get into the bulk of HRT and all of this information, I think it's really important to acknowledge that we're all coming to this topic with different levels of knowledge. And it's really undeniable that menopause is having a moment right now, which is great. It's a really hot topic, which is why I think that this is relevant. But there's also a ton of information floating around there that is very detailed and very complex. And so I heard a statistic the other day. I don't know how accurate it is, but something along the lines of, 4% of the websites out there about menopause are written in language that the average person can understand. And so it really made me think when I was kind of putting this talk together, like what is the relevant information that we need to know, and how can I provide it in a way that you're walking away with more clarity instead of confusion? And I think when we really get into the complexities of it, sometimes you leave more confused. And so I also think that it's challenging as a practitioner to present on this subject, because when we are fielding questions, the truth is most of the time the answer is it depends, which is not a sexy answer, and it's not what people want to hear, but it's the truth, because it really is dependent on where you are at individually, what your health history is saying, what your family history is saying, how you feel about the interventions that are being offered. And so it can be challenging to present information in a way that's going to be relevant for everyone, but I'm going to try to do my best and just kind of talk about things sort of in general. And so the first question I kind of wanted to answer, which I think is an important starting point, is like, what is HRT? What do we call it? And what is it made up of? So HRT essentially stands for hormone replacement therapy. And I would say a more accurate term that we're using today is actually MHT, which is menopause hormone therapy. And so sometimes these terms are used interchangeably. Throughout this talk, I'll probably refer to it as hormone therapy. But that's essentially what these short forms mean. And so I think to understand HRT or MHT or hormone therapy, as you mentioned, let's start with some like very basic definitions. So let's just talk about menopause. So menopause essentially is the date of your final menstrual period for a woman who has a uterus and one or both ovaries. So menopause can be natural, so you kind of move through it as you naturally would, or it can be induced, meaning you've had a surgical procedure or an intervention that has damaged the ovaries and your menopause has been induced because of that treatment.
Can I just ask something? Is it
Yeah.
the date of your last period or the year after the date of your last period?
So that it's actually the date of your last period, because the definition of menopause is actually made retrospectively. So you might be having your last period. You're not aware that that's your last period. Then you go 12 months without a period and you look back and you say, oh yeah, that was my last period. So it's a retrospective diagnosis that we make after you've basically gone 12 months without a cycle. And normally this will happen for women between 40 and 58. Now, I say normally because that's not always the case. And so we need to be a bit flexible about our thinking. But average wise, we would say it's happening between 40 and 58. So perimenopause is another definition, and this really means around menopause. And it includes the span of time, usually several years before that final menstrual period. And I would say usually we identify perimenopause, again, usually not always, but we start to see some cycle changes, right? And so sometimes people will present with period irregularity, right? So their period will start to jump around plus or minus 7 days. You could skip a cycle altogether. Maybe you haven't gone 12 months without a cycle, but your bleeding is becoming more irregular. And that's kind of the takeaway that that we want to identify here, that perimenopause, things start to become irregular, and our cycles maybe don't look the way that they did before. And I think the other really important point to note is that perimenopause is usually the time where we are most symptomatic. And so it's a time where we can see things like hot flashes, we can see night sweats, drastic changes in mood, sleep, energy, even urinary frequency and urgency. And so these symptoms certainly can happen in perimenopause, right? That time leading up to that final menstrual cycle, but they can also continue on after menopause. And so, like I said, I think it's always good to be flexible about our thinking and understand that that's an individual experience for everyone. You could have some of these symptoms, you could have none of these symptoms, you could have all of the symptoms. And so in my experience, things don't always happen as the textbook defines them, but this host of symptoms with the irregular cycles is usually kind of the big ones. And so what's actually happening here? And so what we know is that we're gradually losing our egg cells, or what we call follicles, as we kind of move out of those childbearing years. And so ovulation that, maybe happened like clockwork is really becoming more unpredictable. And we're getting kind of a decline in these follicles. And what happens is we get a major flux in estrogen. And I say flux because during the perimenopause time, it can be like a roller coaster. But I would say the net direction overall of that estrogen is that it's going down. And this flux, this kind of roller coaster, this up and down with sort of net direction being down, is really what makes us not feel well. And so, when ovaries are completely out of follicles, estrogen drops to the level it was before we hit puberty, our menstrual bleeding stops. And so we're kind of in that period where we're not cycling anymore. And in the perimenopause, like I said, in that time frame, it's more of a flux with swinging levels that creates a roller coaster as we transition to that final menstrual period. And so what we essentially recognize is during this time, estrogen levels are moving all around. And so logically, when we look at what is menopause hormone therapy, it's a prescriptive treatment option, typically with an estrogen component, because the estrogen is what's fluxing. And so in perimenopause, the strategy is typically to kind of smooth out these highs and lows. And then, in menopause, it's essentially to sort of replace this declining level of estrogen. And so that's kind of simply put, we've identified the hormone that is largely the issue and that's moving around. And so the prescriptive therapies are designed to sort of replace that. And so, there are a variety of different available products out there that have estrogen in them, right? So they can be prescribed in a pill, in a patch, in gels and sprays. And essentially, they're absorbed into the bloodstream at high enough levels to have essentially a significant, widespread effect at essentially all over the body. And so it's interesting because I think we learn more and more about what estrogen's impact is when it starts to decline. So there's estrogen's receptors everywhere in the body, right? In our brain, in our bladder, in our vaginal tissue, everywhere. And so as it declines, it can create significant widespread symptoms. And so hormone therapy is kind of designed to go in there and to sort of systemically add more estrogen to the body. I would say the one exception to this is vaginal estrogen products that are not designed for systemic absorption. So that's just an important note because these products are available. And so what they do is they deliver a low dose of estrogen to the vaginal tissues without systemic absorption. And so, the vaginal tissues do respond to estrogen, and sometimes there can be symptoms isolated to that area. And so if someone wants to treat, we basically call it the genitourinary syndrome of menopause. If someone wants to treat that, but not have systemic effects of hormone therapy, then they may opt for like a low dose vaginal estrogen that's designed to treat that area. And so, as I mentioned, a typical prescription delivers this estrogen systemically, to help with some of the common symptoms that you're feeling as that estrogen declines. There's also a second component to most of these prescriptions, and it's progesterone. So it's added in for women who have a uterus. And the idea here is if we were to give every woman estrogen who has a uterus, without progesterone, estrogen can stimulate growth, particularly in the lining of the endometrium, which we don't want because if that endometrial lining gets thick, it can be a precursor to cancer. And so if you've looked at a HRT prescription and you have a uterus, you're going to note there's two components. There's usually an estrogen component and a progesterone. The progesterone is put in there so that the lining of the endometrium stays nice and thin, and it doesn't thicken, and then everyone's happy essentially. And so I always say estrogen often is the star of the show. It gets most of the credit because it helps with the majority of the symptoms, but progesterone can also help with sleep. And so, sometimes women will see that benefit, that progesterone is sedative in nature and it helps them with some of the insomnia that they're feeling. So it's not just a bystander, it helps a little bit. And so, that's kind of like your basic HRT prescription. There are newer forms coming out. And I would say they're maybe a little bit less common, but the most common prescriptions are made up of these two components. And so to dive a little bit deeper in this area, I often get questions about whether these forms of hormones are bioidentical. And so I just wanted to touch on this gently if anyone has any questions about that. Again, everyone's coming at this with a different level of knowledge. So when someone asks me about bioidentical, usually I'm trying to understand what they mean by that. And so what I mean by bioidentical is using a hormone that has a chemical structure most similar to what you would produce in your body. And so I think there's a misconception around needing to get that compounded versus using an FDA approved product. And I would say, you don't have to get a custom compounded product to have a bioidentical hormone. And so many of the FDA approved brand name hormones do meet the definition of being bioidentical. And so if you're getting a prescription for, say, estradiol or micronized progesterone, they are technically drugs, but they do fit that bioidentical criteria. NAMS does recommend using FDA-approved products, and the thinking there is that there's more oversight with these products with respect to their quality, their purity, and the consistency of their products, and so they recommend using those instead of a compounded product. And so if that terminology confuses you, or you're not sure what you're using, or you're not sure what your options are, then just ask your provider if you're using an FDA approved product, or if you prefer that, you can always ask. And so, you know, that's a little bit about sort of the granular differences between hormone types. But I also want to say that there are guidelines out there for non-hormonal options. And so if for whatever reason you can't take a hormone therapy, or you don't want to, there are guidelines out there for other options available. And so that's an option for people who aren't, you know, thinking about hormones. So, like, why would we consider taking this, right? Like, what's the benefit, essentially? And so I think that anyone who suffered from aggressive hot flashes might be able to answer this for us, or someone who's suffering from night sweats, which is essentially a hot flash at night. You know, there's certainly a domino effect that can happen, right? So interrupting sleep, therefore affecting energy levels, mood, motivation. I think, you know, there's a huge spectrum in terms of frequency and intensity of these things, and how they show up for each woman individually. And so, you know, hormone therapy in Canada is FDA approved, the first line therapy for the treatment of hot flashes. And it's really the most effective treatment we have for this. And so, as mentioned before, if we're using a bioidentical product, you know, so essentially we're using a product for that's most effective for our hot flashes, that's most similar to what we would have produced on our own, and it's dosed at a level that's similar to the hormones we would have produced in our menstrual cycle, that all seems to make sense. And so, you know, hot flashes and night sweats essentially are the primary indication about why we would think about adding hormone therapy to the mix. But we also know that there can be side benefits too, right? Such as improved sleep, better concentration, bone protection, improved mood, quality of life, which can be very helpful for women during this time. And some of the systemic estrogen can also help with vaginal dryness and painful sex associated with menopause. And so that's kind of like the big reasons why we would think about putting it in. And so when we put it like this, it's kind of like, well, why wouldn't we take that, right? It seems great. And so, you know, that kind of leads to the next question, which is, you know, am I a good candidate? And I think with every decision that we make, this is a good question to ask ourselves. You know, I think that there's a pro and con, or a risk and benefit to every decision that we make in life. And I think that medication or medical intervention is no exception to this rule. And so, you know, just like there are the above mentioned benefits, there's also some risk associated with hormone therapy. And so if we zoom out and we really look at it in a very general way, you know, what are the guidelines saying with respect to risk? NAMS guidelines essentially states that for a healthy woman who has bothersome hot flashes, who is under the age of 60, or within 10 years of her last menstrual cycle, with no prior history of breast cancer, I put that part in because that's a consideration, the benefits of hormone therapy generally outweigh the risk. Full stop. So if we're taking the guidelines for what they're stating, we're saying, okay, if we're under 60, if we're within 10 years, if we have bothersome symptoms, generally the benefit is going to outweigh the risk. I would say, I like to go a little bit further for my patients, and I hold my practice to a higher standard, and I get really granular with each one of my patients, and we evaluate their individual risk, right? So we look at sort of like, what are the benefits, what are the risks, and I think in anything that we do, I think we all need to assess individually our health status and what the risks and benefits mean to us. And I think that's how we make the best decisions essentially in our, like, for our health. And so, I think evaluating these risks and benefits is a really great idea, because especially in today's world, there's so much discussion around hormone therapy that I think most people are really happy to go through this process and really understand why they're making the decision they're making, because inevitably there's going to be a conversation that comes up at a dinner table, and I never want someone to feel like they don't know why they're taking something, or they haven't thought through all the pros and cons. And I really like to empower my patients to have those discussions, or when they come up, they can say, oh, actually, yeah, I've evaluated that risk factor, and this is actually what the numbers are saying, and I feel good about it. And I think that's a really good place to come from. So there's clarity, and you can feel confident about the choice that you've made. And so I think, like most things, the pendulum often swings, right? So it swings from one end to the other, and the answer is often somewhere in the middle. And so, many years ago, tons of women were using hormone therapy successfully. And then the Women's Health Initiative came out, which was a large study that essentially analyzed hormone use. And the takeaway was like very scary headlines essentially from that analysis. And it was sort of like, hormone therapy causes stroke and breast cancer. And so hormone use stopped. And I think, we're still recovering from that. And I think more recently, the findings of the studies have been reanalyzed inside out and backwards. And I think the consensus is now saying that the benefits of hormone therapy essentially were understated, and the risks were wrongly emphasized. And I'm sure we could dedicate like multiple shows to try to unpack that study. It's convoluted and complex, and this is maybe an oversimplification of it, but I think the message I want to state is that I think hormone therapy essentially got a very bad reputation from that study, and most people are still really confused about the findings and the safety and what the deal is essentially with hormone therapy. And I think since that study, our knowledge on hormone therapy has certainly evolved, right? The forms, the dose, the routes of administration for hormone therapy has improved. But again, I don't think it's a pendulum situation where we can blanketly say every woman should be on hormone therapy, or no one should be on hormone therapy. So I don't think we can say that the risks associated with HRT are zero, because they're not. But the risks associated with taking it are uncommon. They go away once you stop. And in general, hormone therapy is associated with fewer than 2 additional harmful events per 1,000 women per year. But again, it's not my role as a provider to evaluate that risk for you. That's your right to essentially evaluate that risk for you. And so my job is to provide the information and to help guide you in terms of supporting your decisions, right? And so I think, again, it's sort of the answer that maybe not everyone wants to hear is that, so, it depends. But I think to truly understand whether or not you're a good candidate, you need to evaluate the risks and benefits for yourself. Sorry. With the guidance of someone who's well informed, even though we know that the risks reportedly are incredibly low, it's still worth that evaluation. And so, essentially, with all my patients who are approaching menopause, regardless of what treatment options are on or off the table, I go through what's called a menopause checkup. And this is where we look essentially at the totality of your health. And the reason for this is menopause is kind of a line in the sand where many of our health parameters begin to change. And having a really good baseline can help us determine what the priorities of your treatment need to be. And so, I mean, you're well familiar with this as well, that we see changes in body weight, in sexual function, in our libido, in our pelvic floor function, in cognition, in sleep, in skin, in hair, in joints, in our mood. And so, you know, a detailed evaluation of where you are and what's going on is really important. And so during these checkups, my aim is to sort of, assess cardiovascular health, look at your metabolic health, look at your diet, look at your lifestyle. We review your history, your family history, and we put all of this together. And of course, while hormone therapy has a role and it can be extremely beneficial, it's not the panacea of health, right? It's not everything. And we all need to take personal responsibility about how we choose to age, separate and apart from our decisions about hormone therapy. We all need to really be aware of what we're consuming from a diet perspective, how we're moving and building strength. Are we prioritizing sleep? What are our stress levels like? And this is a time in general where there's a lot of moving parts for women, I think, in general, right? And so considering our mental health and really working to build great daily habits that can help us to age audaciously, as you said. And I think that we just need to consider all of it versus looking at sort of one approach to fix our health. And I also think that the sooner we become aware of what the priorities and the direction needs to be, the greater impact we can have on preventing disease. We have a longer runway. We have more impact. We can basically impact change when we have a bit more time on our side. So I see this time as sort of an opportunity versus like a disease or a disorder. It's an opportunity for us to really evaluate the checks and balances in our health and wellness and look at all the tools on the table. And so I think kind of to reiterate what I said at the beginning, how do we find support? And I think like most things, the onus is really on the patient to reach out and to be an advocate for themselves, because we know that this area, it's unfortunate, but there's an aging population and menopause care is severely lacking. There's a lack of trained professionals, but then there's also a lack of access to those trained professionals. And so it makes it challenging if you're looking for help, and it puts the onus on the patient to find someone that can support them. And so I think finding a practitioner who's well informed, that can go through your experience and what your treatment options are and put all of this together is helpful. And so I mentioned at the beginning of the talk that the NAMS website is a great organization. It's a great resource. You can actually search for practitioners by postal code, and you can find someone in your area to kind of help review all of this for you. And great resources and handouts there too. So yeah, I hope that was helpful. That's about as brief as I can be with respect to this topic, but I'm happy to answer any questions if people have something more specific they want to know.
Thank you. No, that was all very, very helpful. I think I do have some questions that were sent through. So somebody wants to ask, she said her doctor does not want to put her on hormone therapy because she is still having periods. So this is something I see often in the Facebook groups. What is going on with that, and what is your advice to people who get that kind of response from their doctor or their OBGYN?
Okay, so that's a great question. And this is where I said sort of at the beginning that we need to be a bit flexible with how we think about things. And so one of the primary indications for hormone therapy is hot flashes and night sweats. So you can certainly be cycling and be getting those, right? And so again, yeah, I think if you have an indication and it's one of the primary reasons as to why we use hormone therapy, then it is a treatment option. So if you're still cycling or you have a period, I don't think you should be denied hormone therapy provided there's an indication. So that might not be the right advice for that patient.
Right. I think that there's still a lot of confusion, and maybe many doctors are not necessarily up to date about, you go through perimenopause, you don't go through menopause, right?
Yeah.
And as you said, a lot of the symptoms that we're feeling are happening during the perimenopause stage and not the post-menopause stage.
Yeah, and I think it's also important to think about the transition like this, right? So it's a meshing of different stages, right? It's not like we wake up one day and we're in perimenopause and then the textbook says the next day we're in menopause. It's a blend of all of these things. And so we need to be a bit flexible about what are the reasonings as to why we are considering hormone therapy. If there's an appropriate indication, then we have a strategy, right? And so yes, you can be in late perimenopause, for example, where you're missing a cycle here and there and you're having hot flashes. That's very common. And the other thing I'll say is that there's also like a lack of research in this area. There's a lack of training, but there's also a lack of research in this area too. So sometimes it causes us to have to pull forward or pull back what we know about menopause and apply it when we're trying to support patients.
Amazing. Thank you. Another question we have here is, I am prone to breast cysts. Is hormone therapy appropriate or not?
So again, it would depend, right? And so usually a contraindication is if we have a personal history of breast cancer, right? So that is a known contraindication for hormone therapy. Cysts is not cancer. And so again, you might want to walk through, is that patient having regular mammograms? Are they being evaluated? What screening protocols are in place to ensure that we know and can say for sure that the breast tissue is cystic? And so I would say that's kind of the best way I can answer that we know a known contraindication is breast cancer. Cysts are not breast cancer, so they're not the same thing. But again, you would want to chat with someone individually about what your breast history is like and whether or not hormonal therapy is appropriate.
Awesome. Thank you. Another question we have is, can you be on hormone therapy for the rest of your life? Or is there are there time specific periods when you should come off?
So that's a great question. I would say that there are no guidelines for when you have to stop your hormone therapy. And this is why when someone is on hormone therapy, we're doing regular follow-ups, because at those follow-ups, we're always weighing the risks and benefits. Is this still a great option for you? Is it not? Do we need this anymore or do we not? And so there are no guidelines. It's an individual choice as to when you decide to do that, right? Some women will come off and some, mild symptoms will creep up, and that might influence their decision. And so I would say right now, the guidelines don't say you have to come off at a certain date, but you need to have an ongoing discussion around pros, cons, benefit, risk. Is this still a good option for me or not?
Awesome. Thank you. Well, Tamara, thank you so much for coming to chat
You're
with us
welcome.
today. If you're watching on the replay, Tamara will be available to answer your questions. Just type #replay, and we will be checking comments of this in the Moving and Reshaping Club Facebook group. So just type in Moving and Reshaping Club for Peri post-menopause, and the group should come up. And this post is under the featured section, so it's super, super easy to find. And just to reiterate for the people in Ontario, Canada, where you practice, you are able to prescribe, is that correct?
Yes.
Amazing, amazing, because I know that there are lots of people looking for well-qualified menopause practitioners who can prescribe medication. So that is amazing. Go and check Tamara out at her Instagram, which is, can you tell us what your Instagram is again?
It's Dr. Chaddah ND.
Fantastic. Well, thank you so much
You're so welcome.
for just today. Really appreciate it. Huge topic.
Yeah.
And I hope you will come back and chat to us again.
Okay, great. No problem.
All the best.
Take care.
Bye.